Obviously most strokes are caused by a blocked blood vessel in the brain, and we've had the clot dissolving treatment TPA for 20 years now, and it does a great job of reducing disability from stroke. But in patients with a large vessel occlusion, so say the internal carotid artery or the middle cerebral artery, it's not so effective in quickly dissolving that clot. So over the last few years there's been an evolution in the range of devices that can be used via an angiogram to physically remove the clot, and we were using the Solitaire device. It's a stent that you put in the clot and then remove under negative pressure, so it's not leaving the stent in place, it's just using it as a retrieval device. So we took patients who were receiving TPA within 4.5 hours, had a major vessel occlusion in the internal carotid or middle cerebral artery, and also had a favourable imaging profile. So we were using CT perfusion imaging, which is a way of imaging where the blood flows in the brain, and identifying patients who had a relatively small area of irreversibly damaged brain and a large area of potentially salvageable brain. So patients who really should respond very well to reperfusion if you can achieve it. So in that group of patients that were carefully selected, the Solitaire stent retriever opened the artery much more than TPA. It was 89% had achieved more than 90% reperfusion by 24 hours compared to 34% in the TPA group. So it's a massive difference in opening the artery, and that translated to a benefit in early neurological recovery, which we looked at 3 days using the National Institutes of Health stroke scale. That was substantially increased as well. And then the functional outcome at 3 months, which is what we all care about in stroke trials, the modified Rankin scale. So independent outcome, a modified Rankin of 0 to 2 was achieved in 71% of the stent thrombectomy arm versus 40% of the TPA only arm. So that's a number needed to treat, if you like, that statistic of, for every 3 patients, an extra patient gets home to independence, doing all their usual activities. So it's a massive benefit for the patients. On the shift analysis, so looking at benefit across the range of disabilities, also highly significant benefit for stent thrombectomy. So the 3 trials that were presented as new trials here are all incredibly consistent across their results. The means of selecting the patients was slightly different, but the key was to identify patients with minimal irreversibly damaged tissue at the baseline. And we used the CT perfusion technique. In the SWIFT Prime trial, they mainly used that technique as well with some automated software called Rapid, which was created by Stanford University. And that really makes it a lot easier for different sites that may not have had experience with this advanced imaging to apply it in practice. It's a fully automated process, so there's no technical processing required. Makes it a lot easier. The ESCAPE trial from Canada used a slightly different approach with collateral scoring. It's just a matter of what you find is most effective in your centre, really, but the key is to treat quickly, to use an effective device, and these stent thrombectomy devices are clearly much more effective than the previous generation of devices, and to use something that's going to identify patients that don't have a large amount of already dead brain tissue, because those patients don't tend to respond very well, and there's a risk of opening the artery in those patients as well of hemorrhage.